Good morning, good afternoon, good evening, wherever you are. Thank you so much for joining the YouTube live stream, Emergency Questions and Answers for Families in ICU and Intensive Care at Home. I also want to welcome our viewers on replay, because I know we have quite a few viewers on replay as well. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I want to welcome you to the show. Before I go into today's questions, today I only have about 30 minutes, so I do apologize. I do have to get on a client call in about 30 minutes. So normally I go for an hour, but today I only have about 30 minutes. So my apologies straight away. If you have any questions, type them into the chat pad or connect with me live here on the StreamYard link. I am just posting my StreamYard link in here in the chat pad. So I can see there's quite a few people here, so thank you for joining. Once again, my name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. Welcome again to the live stream. What makes me qualified to host a live stream for families in intensive care and intensive care at home? I'm a critical care nurse by background. I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com. And you can verify that on our intensivecarehotline.com podcast section, where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home 24 hours a day as a genuine alternative to a long-term stay in intensive care. And we're basically providing an intensive care in the community, staffed by highly experienced critical care nurses. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are an NDIS-approved service provider, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the DVA all around the country. We have also received funding through public hospitals, private health funds, as well as departments of health, and so have our clients. And we're also providing level 2 and level 3 NDIS support coordination. Now, without further ado, let's dive into today's questions. And before I look at the questions that have come in during the week, if you have any questions, type them into the chat pad or connect with me live on the StreamYard link here that I just posted in the chat pad. So let's get started. I have an email here from David who says, "Hi Patrick, I'm trying my best to give my mother Debbie a proper end of life at our home on a feeding tube, tracheostomy and ventilation. We are interested in your fine work with intensive care at home and help. I have just left you a phone message with a callback number, and thank you for your time and consideration. Yes, I know you have left a message for me, but I have also called you back and you haven't responded to me, which is why I thought I am addressing it here. So David, if your mum is in ICU with a feeding tube, most likely a PEG tube, most likely a tracheostomy and a ventilator, and she can't be liberated from any of it, and you think that your mum is in an end-of-life situation, then I agree with you that home care is the much better option here. Now, the other question here is your mum, maybe she's not end of life. I mean, how much do you know and understand about your mum's situation? Maybe the intensive care team has planted the seed for you that your mum is dying. I don't know. It is always helpful for us if we can look at the medical records. That is always helpful for us, because then we can make a proper assessment of what's really happening, and we can map out the course of action. In my nursing time and my nursing career, I've looked after hundreds, if not thousands, of critically ill patients and their families. It's always good to have someone else looking over medical records, talk to doctors and nurses directly, And, you know, that always helps. You know, you never just want to have one opinion. But I can also understand that with your mom being stuck in ICU on a ventilator with a tracheostomy and with a feeding tube, I can understand that you're looking for alternatives, and that's a good thing. You know, ICU is very good for, you know, the acute onset when someone is critically ill, but it's not good for anyone that's sort of stuck on a ventilator with a tracheostomy long term that can't be liberated from that. But the other question in a situation like that, if they can't be liberated from the ventilator and the tracheostomy, is, are intensive care teams doing all the right things? Or are they trying to create a narrative that may suit them, but doesn't necessarily suit you? You know, those are questions you have to ask yourself. You know, what else is happening? What else is happening? You know, is your mom off ventilator, of inotropes? Is your mom off sedation? You know, what's really going on? It's great to know that your mom is on a ventilator with a tracheostomy and a feeding tube, but also with the feeding tube even, is she having a PEG tube or is she having a nasogastric tube? You know, the devil is in the detail when it comes to intensive care and, you know, the treatment. You know, the devil is absolutely in the detail. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care, right? So, you know, for example, if your mom has a nasogastric tube, right, that may be okay if she's going home for end-of-life care, for palliative care. If your mom is not palliative care, then I would advocate for a PEG tube, right? And whilst I advocate in many cases against the PEG tube, in this situation, I would advocate for a PEG tube, right? Because in a home care environment, a PEG tube is the safer option for someone that can't be weaned off the ventilator. But at this particular point in time, I don't know enough about your mom's situation, whether she can or she can't be weaned off the ventilator, right? But let's look at the logistics, irregardless of whether your mom has a PEG tube or a nasogastric tube. You know, both is possible for going home. Don't get me wrong. We can do both at home. We've looked after PEG tubes at home. We're looking after nasogastric tubes at home. Doesn't make a difference for us, but it does make a difference for the patient, right? That's the bottom line. It does make a difference to a patient and their families, of course, you know. So let's look at the logistics getting your mom home. Well, first of all, let's talk to the doctors and nurses there directly. Let's look at some medical records, right? Let's look at the discharge plan. Has the hospital and the ICU looked at the discharge plan? I doubt that they have, because, you know, they have limited experience when it comes to intensive care at home. They don't really know how to facilitate the discharge from the intensive care unit to a home care environment. They don't really know how that works. But that's where we come in. That is our area of expertise. That's what have we made our specialty, right? That is what we have made our specialty, how to take patients home, make a successful transition from the intensive care unit to a intensive care at home environment, right? And given that you are reaching out to me, David, I know you have a need for that. Your mom has a need for that. You're probably sick of your mom being in ICU. Your mom is probably being sick of being in ICU. You and your family are probably spending day and night in the intensive care unit. And I'm sure they've done a good job to keep your mom alive to this point. But now it's time to look at what might be lying ahead, right? So, what needs to happen next, right? What needs to happen next is we need to create a discharge plan. That's number one. Number two, we need to look at the financing of it all. But the financing of it all is much easier than you think it is, quite simply because an ICU bed costs $5,000 to $6,000 per bed day. Let that sink in. $5,000 to $6,000 per bed day for an intensive care bed, right? With intensive care at home, we're slashing that cost to around 50%, right? So depending a little bit on location, $2,500 to $3,000 a day. It depends. Some of it depends on location, quite frankly, right? The further away a location from a metropolitan area, the more expensive it is to create, to provide the service, of course. But we are serving quite a few rural and regional areas, and it is absolutely possible, right? So, once again, whoever's paying for the ICU bed right now would have an interest in paying for home care for 50%, right? So there's a business case in there. That's very important. Now, that is important in light of improving quality of life, of course. That goes without saying that taking your mom at home will improve your mom's quality of life and potentially quality of end of life. Once again, maybe the ICU team has created a narrative of end of life care, which may or may not be accurate. Okay. Then what else needs to happen? What else needs to happen is, we need equipment. We need ventilators, or at least 2 ventilators at home, one at the bedside, one as a backup ventilator, or for community access, suction machines, 2 suction machines, bedside monitors, humidifiers for the ventilator, HME filters for community outings or for community access, probably a hospital bed with an air mattress, probably if your mom is immobile, a lifting machine, a hoist, right? For most long-term patients, they have a ceiling hoist installed, right? But with the ceiling hoist, the question is, is that necessary? Will a portable hoist, a mobile hoist do for now, a mobile lifting machine? I don't know, that it's really up to the situation. Is it going to be a long-term situation? Is it going to be a short-term situation? All the rest of it, right? Also, like I said, and like I have been saying for a long time on this podcast here, that most of our clients, without exception, have community access, even when they are in palliative care, right? The problem in an intensive care unit is that, everything is focused on treatment in intensive care in a hospital bed space, in an ICU cubicle, whatever you want to name it, in an ICU room, right? And no one is looking at, well, what else can we do outside of that room? When sort of the critical phase is over and patients are more stable, that's when you need to look at, okay, is that all we can do? Or is there a better approach, right? And, if patients are medically stable, they're off iron drops, but they're still life support dependent, i.e. ventilation, tracheostomy, then, the next step is to get them home, look at community access, right? Let's start in age brackets, really, for our pediatric clients, they can go back to kindergarten. They can go back to school. For our more teenage age clients, they can go back to college and high school and university, right? We've done all of that. So that is what an alternative looks like to a long-term stay in intensive care, even if clients are on ventilation, tracheostomy without ventilation, BiPAP, CPAP, even if they're on TPN, doesn't matter. Anything is possible with the right level of support, right? So you really don't even want to sort of talk about the cliche. You have to think outside of the box, because we're not thinking outside of the box. We're just doing what we're doing, and we're doing what is right for patients and for families. It's not thinking outside of the box. It's just doing what's right for patients and for families, right? You just have to put the right infrastructure in place and the right thinking, and the right people, of course. Nothing happens without our people. And, at this point, I do need to give a big shout out to all of our nurses on the road that are doing amazing work with our clients, keeping them out of ICU, getting them out in the community. So big shout out to our team that's on the road now on a Sunday. It's out with clients, keeping them at home, saving 50% of the cost of an ICU bed. But, besides that, they're delivering a service to patients, to clients and their families that they actually want, that doesn't confine them to an intensive care bed in a hospital, right? So, David, to come back to your question, what else needs to happen? Of course, I talked about equipment now. I talked about money. I talked about funding. How is it being funded, right? And then team. What sort of team? How that works is, generally speaking, you want a team of people that like, and trust. Now, can we get you people that like, and trust from day one? Probably not. Can we get you people there from day one? Absolutely, yes. The way this, generally speaking, works is whenever we're starting with a new 24-hour roster, we find staff, sometimes existing staff that want to do more work. Sometimes we need to hire from scratch, depends on the location, depends how busy we are, and then we'll get you staff there, all experienced critical care nurses. But at the end of the day, it all comes down to, are those critical care nurses the right fit for your home, for your mom? People that like, and trust. And we know the importance of that. And what often happens is, after a few weeks, sometimes a few months, you will tell us, hey, I really like those people, but I would prefer having only those people, and maybe we can use the other people not so much. And I understand that it's a very unique service that we're providing. It's in your home. You need to feel comfortable. I need to feel comfortable as a business owner that I'm sending you the right staff. Otherwise, it's going to be very difficult for me to sleep well at night, if that makes sense. So, there's a number of nuances that need to be looked at here. But the bottom line is, in an ICU, for example, you don't get the people like, and trust most of the time. You just get the people that they send you, and you have very little, if any, say, right? So, with us, you have more choice, not from day one, but as time goes on, if that makes sense. We always try and involve our clients in the staff selection process. We try to set up, meetings with clients upfront so that the families can meet our staff, of course. Some clients don't want that, and, they're happy for staff just to come. Others want to meet the staff, and that's fine. Whichever way you want to go about it, that's absolutely fine. Just rest assured that we do have staff available that want to work with us, that want to work for us. That's the process in a nutshell. Then the question also comes in, what's the medical oversight to be like? So that depends a little bit on the location also, right? So I'll give you an example how the medical oversight works. Generally speaking, a patient goes home with a care plan, okay? And that care plan needs to be detailed, right? Needs to be detailed. This is what a patient should have, medication-wise, treatment-wise, and so forth, right? And that should be sort of how a discharge should be approached, right? Now, if the situation changes, right, sometimes a GP or a family doctor might be okay, especially when it comes to maybe prescribing antibiotics, treating an infection, simple things like that. But when it gets more complex, sometimes the discharging hospital, the medical team is happy to be involved. Sometimes we have our own private intensivist, ICU consultant that can be involved. Sometimes it can be a respiratory physician. Sometimes it can even be a hospital, another hospital. And I'll give you an example here. Our main client base still is in Melbourne, Australia. And a lot of our adult clients are coming through the Austin Hospital, the VRSS, the Victorian Respiratory Support Service, and they pretty much, provide the medical governance. But that is for the state of Victoria in Australia. That's unique to that. Right? In other states, it is more fragmented. But, we are getting a larger and larger client base in other states as well, whether it's in New South Wales, whether it's in Queensland, whether it's in South Australia, whether it's in Western Australia, right? And the medical cover is always there. It just really depends on the situation. I will say this, that the best model we have found is actually the VRSS, the Victorian Respiratory Support Service, because it comes through a public hospital and there's always a registrar or a consultant on the other end of the line, because they obviously have an interest in keeping our clients at home too. Right? That is the best model we have found so far, but that doesn't mean another model in other areas isn't working. It is clearly working. Otherwise, we wouldn't be in business, right? So it is clearly working. So I hope that helps you understand, David. And also, if, God forbid, your mom's situation is an end-of-life situation, right, then we should also look at getting a palliative care team involved, right? And once again, depending on location, you haven't shared your location yet, depending on location, we can look at that and help you with sourcing and working with a palliative care team. Because it is very important that the right people, the right specialists are involved from day one, so it's not getting pear-shaped. The last thing that you want, and that we want as well, is for your mum to go home, then the right teams and the right resources are not in place. What happens then is only your mum will only bounce back into hospital, and you don't want that. That's the whole purpose for you to reach out to us, that you want to keep your mum at home predictably. And I think that's really what is important to understand here, the word predictably. We want to keep our clients at home predictably, and that is very important. That's peace of mind for you, peace of mind for your mom, but it's also peace of mind for us. We are here to keep our clients at home. That's the core business we are in. That's the core service we are providing, to keep our clients at home predictably, right? So, so that is pretty much, summing it up, how we can help your mom, Debbie, to go home, David. It's a complex process, but a process we have taken on over and over and over again, so we know how to steer the ship. Another thing that I forgot to mention is you will also, and we will also, need to liaise with an occupational therapist, to make a transfer home safely, a physical therapist, a physiotherapist, to look at physio at home, right? Another thing that I forgot to mention, again, depending on your mum's situation, why she's in ICU, you haven't shared any of that. Does she need other equipment, such as a cough assist machine, for example? She will need a nebulizer, all of that. So, the devil is in the detail. The devil is in the detail, and it takes a team, right? It takes a team to make that happen. And the team, like I said, includes us as a nursing service, of course. It includes the medical governance. It includes an occupational therapist. It includes a physiotherapist. It includes a dietitian, a speech therapist. It's a team of people. It includes equipment suppliers. It includes a funding body, of course. There's a team involved, right? But all doable, all doable. So, Helene, you are asking, would a PEG tube be more beneficial and to prevent aspiration pneumonia? It depends. There's probably more pros to a PEG tube to prevent aspiration pneumonia than cons. There are. I know you're a regular follower of my podcast, Helene. Whilst I'm advocating against PEG tubes in most cases, that is for patients in intensive care. For a home care environment, for someone that needs long-term ventilation, the PEG tube is the safer option to prevent aspiration pneumonia. But for someone who has nurses 24 hours a day and may only need temporary enteral nutrition, the PEG tube should be a last resort. But to answer your question, PEG tube would be more beneficial to prevent aspiration pneumonia. Yes, more pros for a PEG to prevent aspiration pneumonia. There's a higher risk for a nasogastric tube for aspiration pneumonia. Yeah, I hope that answers your question there, Helene. So if there are any other questions, please type them into the chat pad. Unfortunately, today I need to keep this short. Normally I go for an hour, but today I need to get on a client call in about 5 minutes. So I do apologize. I will be back again next week, you know, at the same time, and totally going for an hour next week again, like I do with all of my other videos. So, but you know, because we've been spending so much time today on David's email, you know, that he wants his mum home. You know, for anyone watching this live or on replay, you know, going home from intensive care on a ventilator with a tracheostomy, or if you are in the US and you have your family member in ICU, or if your family member in LTAC, going home is absolutely possible. I'm not aware of any providers in the US. We are aiming to come to the US, but we're not there yet. You know, for now we are sticking in our territory in Australia, but we know there's a huge demand in the US, and I wouldn't be surprised if, you know, some of the viewers today are watching this in North America, same in Canada. You know, we want to help the North American market, but we're just not there yet. Logistically, we are so busy here, you know, but keep your questions coming regardless. You know, we want to help you there as well. But it is absolutely possible. Do not let anyone persuade you that going home with a tracheostomy and a ventilator isn't possible, or that because your family member has a ventilator and a tracheostomy, that the only way forward is end-of-life care, that the ventilator should be stopped. We have plenty of people living in the community with ventilators and tracheostomy that can live for a long time to come, and they want to live, right? They want to live, you know. So because they want to live, we're providing the service for that. You know, I know anyone watching this can think for themselves. They don't need to get bogged down by negative ICU narratives about, you know, that people won't have any quality of life, blah, blah, blah. Well, people have quality of life in the community. They have actually a much better quality of life than, quote unquote, living in an ICU. You know, living in an ICU is not a good way to live. Living at home is a much better way to live, you know. And once again, maybe you're watching this and you're from an insurance agency, maybe you're from the NDIS or from any private health insurance. If you're watching this, you know, we are a cost-effective option. We are a more cost-effective option for a long-term stay in intensive care. And you can provide your members with the quality of life they want. I do need to wrap this up right now. Thank you so much for watching. Go and check out intensivecarehome.com and intensivecarehotline.com. Thank you so much for watching. Look out for my quick tip videos during the week, and I will talk to you again next week, same time, on this YouTube live stream. Have a wonderful weekend, and thank you so much for joining. Like the video, subscribe to my YouTube channel, share the video with your friends and families. Leave your comments so that I know what content you want me to create. Take care for now.